going to be talking about potassium electrolyte today in our patient's body. And again, like we talked about with sodium, I want to refer to the compartments in your body of fluids. We have vascular, interstitial, and cellular. And where we find the majority of potassium in these compartments is actually cellular. We actually have a high concentration of potassium in our cells as compared to outside of our cells. And as a result, the lab that we get from our vasculature serum shows that our normal ranges for potassium are 3.5 to 5.0. That is much lower than sodium, which has a high concentration out in the extracellular area. And so as a result, it takes very little potassium outside of the body to do the big job that it does outside. The majority, as I said, are inside of our cells. And the reason it is because we have that sodium-potassium pump where we pump sodium out of our cells while we take in potassium inside of our cells. And if we were to put a probe inside of a single cell, we would probably find a pretty high concentration of potassium, just like we find a high concentration of sodium out in our vasculature. So potassium is very high here, very low over here, but has an extremely delicate level change here. By being this low, it really doesn't take much to change potassium levels as compared to sodium. Sodium is like it's in an ocean. This is like it's in a small swimming pool. And so we have to be very careful about changes in potassium because a little bit can go a long ways in our extracellular area. One other thing to note is that because our cells pump out sodium, there's nothing else that is comparable for our cells that could be exchanged for potassium. So sometimes we'll talk about this later, hydrogen can sometimes be exchanged with potassium when it comes to the cells. Now, how do we regulate potassium outside in this area? Because it's very important that we consider how do we keep the levels that we need to. And the big organ that does that is our kidneys. Now, does our kidneys have anything that directly affects them with potassium levels? No. It does it indirectly. And that is with the RAS system. Remember that the RAS system is about holding sodium into the body. So as sodium is retained in exchange for sodium, potassium is lost. And so we have to think about how does our kidneys deal with potassium. It does it indirectly. Now, can the kidneys shut off the flow of potassium and keep it in if it needs to? And the answer is no. It can actually slow down the loss of potassium by letting go of some sodium with the RAS system slowing down, but it can't stop the loss of potassium. So it's a very, very important concept. Our patients won't stop losing potassium. As a result, in order for us to maintain our balance, we have to make sure that we have a good intake of potassium to keep up with our loss of potassium that's happening with our kidneys. And you'll find, if you look in your dietary book, that a majority, if not all the food groups, have potassium in them. Because it's found inside of cells, it's found inside of meat, you have it in milks, even some of your vegetables and your fruits, because it's in the soil. It's all part of much of our food intake products. So it's very important that our patients eat. And again, there are some foods that have more than others in it. But that is how we regulate potassium in our bodies. We're going to move on to talking about hyper and hypokalemia. All right, we're talking about potassium, and we're moving on to talk about the mechanisms of what will cause hypokalemia, less than 3.5, or hyperkalemia, which is greater than 5.0. So let's talk about hypo. What could cause us to have too little potassium in our bloodstream? And one of the ways is to not eat it. As we mentioned before, that all foods have got a certain amount of potassium in them. So by not eating, you're not replenishing what you're losing from your kidneys. So start starvation is one way to do it. Kind of similar to that is, say you do eat, but it moves through your GI system too quickly in the form of diarrhea. And that will also cause you to lose potassium out of your body before it has a chance to be absorbed by your vasculature to be available for the vasculature. And then remember that we have potassium inside of our cells, of our body. And so we have to think about, this is where the majority of potassium is. So what may cause you to have too low potassium? Well, it's possible to pack more potassium inside of your cells. But in order for your cells to want to do that, something has to be different out here in the environment. And one of the things that we can do is have an alkalotic patient that has alkalosis out here. What does alkalosis do? It's base, so it wants to pull hydrogen to balance it out so it's not so acidotic. And where does it get the hydrogen? Is from inside the cells. So if hydrogen is pulled out of the cells, something has to replace it, and what can replace it is potassium. And that can lower the potassium level outside in the bloodstream. Another thing that can cause your cells to sequester more potassium is to grow a bunch of more new cells. And if you have more tissue repair that's faster than expected, you can have a lot more potassium sequestered into those new cells, and that may also lower your bloodstream amount of potassium. And then the last thing to consider with hypo is your kidneys. This is usually a big culprit of potassium levels going low because you can lose a lot more this way and a lot more quickly than you sometimes think about or expect, because we do a lot with our kidneys in the clinical area. One of the big drugs that is used are your diuretics, especially loop diuretics. They will definitely lose potassium out of here. We also give our patients many times IV fluids for various conditions. And IV fluids, if they don't have much of any potassium in them, will dilute and also bring down your potassium level. And then another way can be sometimes the drugs that we give that stimulate or sequester sodium in exchange for potassium. And steroids are a good example of drugs that will keep sodium and lose potassium, and that may change your amounts that you have in your bloodstream. So the kidneys are a big deal when it comes to hypo or losing potassium, because they're commonly using potassium all the time. The next scenario is, what about a patient that's hyperkalemic? What changes in this picture when we're talking about hyperkalemic? And why do they have that? So in this case, you would have a patient that might have an excess increase in their diet. Now, it's kind of hard to do because even if we do eat more in our diet, usually our kidneys can kind of help get rid of that. But it's possible. Or we're giving a lot of potassium pills in our clinical area, thinking that we have someone with low potassium, and we didn't check, and now the potassium's high, and we give them more pills. And that's another way to bring it up. And then a third way might be kind of like we talked about with sodium, and that is if we decrease the water, they become dehydrated, and we have problems with balance in water. Sometimes that can change our potassium and make it high, artificially high. So GI-wise, we don't usually have a problem with that. The cells, on the other side, instead of having problems with alkalotic, if we have an acidotic patient with acidosis going on, that will push hydrogen in to the cells while pulling potassium out, and that might raise our potassium levels out in our periphery. Another issue would be tissue injury. If we kill some cells, they get injured, and a bunch of them get killed so that they are lysed and opened up and they release that potassium, then if you have too many of those, that can raise the amount that's in your bloodstream. And then finally, when we're talking about the kidneys, the way to bring potassium too high into your levels is to have, you should say, renal a definite way to bring your potassium level up in your bloodstream. When we talk about drugs, we have potassium-sparing drugs that can also raise up your potassium levels. Usually not a whole lot, but if you use them excessively, it's a possibility that it might. So shutting down the kidneys, changing the conditions of your cells, and doing anything with your intake, your GI tract, those are ways that we influence the levels of potassium in your bloodstream. We're going to move on and talk a little about the purpose of potassium now and what it will do to the patient's symptoms. So now we're talking about potassium and what the purpose is. Why do we need potassium outside of our cells in our vascular system, in our interstitial area? What purpose does potassium have that makes it so important? And you have to go back to your physiology and remember that our nerve cells, when they deal with the exchange of your sodium potassium between the nerves, it actually sets up your electrical impulse that gets read by your muscles. And so potassium is very, very important for nerve conduction with information to tell your muscles what to do. And it's your muscles where we start to see the signs and symptoms and problems with having a lack of or change in your potassium levels. And the muscles that we are most concerned about happen to be your heart. They also are your skeletal. They're also your GI. And then they also are your respiratory muscles. And so when we talk about symptoms of hyper or hypokalemia, we are talking about seeing symptomatic changes in the muscles that work these particular types of areas. So when we talk about having too low of potassium, hypo, we're going to see slowing down of this conduction. So we'll see these muscles slowing down and not functioning as well. We can actually see on an EKG, if you remember, you have a P wave, and then you have a QRS, and then you have a T wave. When it's too low, you have an inverted T. And then on the other side, when you have too high a potassium, you're going to be seeing an EKG with P, QRS, and then the T actually peaks up instead. So it goes the opposite. So with low potassium, things slow down. So we get a slowdown. When we get too high a potassium, we get hyperactivity. And so we can see problems with these muscles also doing too much or going too high and hyper where they shouldn't be acting. And so these are how we see the symptoms. It's all based back to the nerve and nerve conduction and the effect that potassium has. Last, we're going to move on and talk about how to treat potassium issues. Now we're going to talk about how do you treat hypo or hypokalemia, and what are the steps and thought processes that go into treatments of it. So let's talk about a hypokalemic scenario where you have too low potassium. Very, very important to get that up. It can be done orally, and as we talked about, we had foods that have potassium in, but again, we don't know how much potassium is in each food, so more likely we're going to give the patient pills with certain milliequivalents of potassium. And again, the most common is 10 to 20 milliequivalents orally. You might have to take several of that throughout the day to get that to come back up. If a patient is extremely low, and we're usually talking about it being below 3.0, we want to get it up faster than waiting for pills and digestion. We're going to be giving it IV. And it's very important that you know the concentrations of potassium. Majority of potassium that you will see, if you were to go into a staff medication room and pull out an IV, it's probably going to have that 20 milliequivalents added to it when it has potassium in it. And this is a standard amount that's very common, but the reason being that this 20 milliequivalents, if you give it IV, it approximates what is lost by the kidneys. So I refer to this as a maintenance dose of potassium, and you can't overdo, you can't give them too much potassium with this. As long as you have a patient with a normal functioning kidney, 20 milliequivalents will maintain their levels in the bloodstream. So this is not to correct it, this is just to keep it maintained. If you remember, if a patient's NPO, which we often do in the clinical area, they're not getting the food, we have to make sure that they often get the potassium, and so we often put IVs with 10 to 20 milliequivalents up for them to have. And so this is safe to give, that's why they stock it up in the rooms. Anything higher than this though, which can be anywhere from 30 to 40, we could do 60, we could do 80 milliequivalents, is to correct and to bring up somebody's potassium levels. So these have to be specially formulated and made. They're usually not stocked on the units because we don't want to incorrectly grab the wrong solution and possibly elevate somebody's potassium. So these are done and ordered. And one of the things to remember when you are giving potassium IV that's in these larger doses to correct it, you want to make sure that you don't give it too fast. But again, we have to correct this potassium levels in a rapid enough way that the patient's not going to suffer for it. So they tell us that we should go no more than 10 milliequivalents per hour IV without having a monitor. If we have to go faster, we would need an EKG monitor to make sure that we aren't overcorrecting it and going the other direction. But if we're not monitoring or we have a patient that needs it quickly, IV, this is the standard med-surg unit rate that we run it at. And if you have a 60 milliequivalent dosage of your IV, you're going to be running that over 6 hours. If it's 40 milliequivalents, you're going to run it over 4 hours. And that's what you should expect to do when we're giving IV amounts of corrective solutions of potassium. Okay, we don't have really any way that we correct potassium in relationship to our cells. The other way is to think about the kidneys and losing it. And we might, if a patient needs to have diuretics, we would want to use a potassium sparing diuretics. So if we need to get fluid off, that would be the suggestion here. But mostly when we have hypokalemic, we're going to be correcting it either by intake of food and pills, and again, we tend to do it at milliequivalents of, 10 to 20. And usually we're talking about a potassium level about 3.0 to 3.5. We're correcting it orally with pills. When it starts to get to below 3.0, so less than 3.0, we're going to correct it IV and get it done quicker. All right, so that's hypo. Let's talk about hyper, having too high of potassium. How are we going to correct for that? Well, we can try to decrease it with a diet, having a low diet of potassium. And again, many times that's not a very appealing diet. It has less of your fruits and vegetables and good kinds of wholesome things, but some of your more refined foods. But anyway, we don't usually rely on that as being the way to do that. Another way that we can deal with it from the food aspect is the GI tract. We do know we can lose it through the GI tract if we have diarrhea. So there is a drug called K-Exolate. It's a liquid medication the patient can take, and it will actually draw potassium out of the bloodstream, kind of into the GI tract, and actually in exchange for sodium and calcium. You have to be careful about that because it could raise a patient's bloodstream of sodium or calcium a little bit. But it's going to pull the potassium out, and then the patient is going to have diarrhea, or they're going to lose it via the GI tract. So K-Exolate is a drug to help pull it out. Another way is to look at our cells. And I'll put a big cell over here and draw a picture of that. And if you remember, we talked about, we have potassium in here. We've got hydrogen. And so if we need to quickly get rid of the potassium in the bloodstream, sometimes we can hide it temporarily inside of our cells. And there's a way to do that treatment-wise. And so what we will do is we want to put potassium from outside here inside of the cell. So we have to draw the hydrogen out of the cell, and the thing that's going to draw it is to make it more alkalotic out here. Alkalotic. And so we're going to do usually bicarb. We can put bicarb in an IV, and we can actually make the patient more alkalotic, and it's going to cause potassium to go into the cells because it's pulling hydrogen out. Another thing that will help potassium better get inside of that cell is actually insulin. Insulin will help that process of pulling the potassium inside of the cell. And we have to be careful. This isn't just for diabetic patients. We can give insulin with bicarb to a patient, and if we give the patient half that, we have to make sure that they also get some dextrose, that they get some sort of glucose with that insulin, because we don't want to drop their sugars abnormally. And so temporarily, with this process of giving bicarb IV and making sure they get some insulin with some sugar water IV, we can actually temporarily cause the potassium levels to go down. Now we have to think about correcting whatever the problem is that's causing that eventually, but that's a temporary way. And then the last way that we can talk about losing or getting rid of potassium is definitely our kidneys. And probably the biggest drug for doing that is going to be our Lasix. Our Lasix is our loop diuretic. It's going to be the best drug for getting rid of potassium levels. Unfortunately, if you have a patient with kidney failure, then we're talking about this not necessarily working on their kidneys. If they have a problem with kidney failure, the last resort is your hemodialysis. And that is, when we have patients with kidney failure, is really the only way that they can bring their potassium levels down. Because we can't get them to quit eating. They have to eat, so they're going to be getting potassium all the time. And then we have to make sure that they get their potassium taken off with dialysis. And that is it in a nutshell of how we treat patients with potassium levels high or too low.